Thank you, Jenna. Good morning, everyone, and thank you for joining us today. I will be going over some updates from our HAI-AR program for the state of Nebraska and kind of talking about what we intend to do as we go forward. I do have a disclosure. I have received funding from Merck, but there's nothing directly in conflict with this presentation. These are the objectives of the talk today. We'll try to cover all of those. And then just wanted to kind of remind the structure of the program that we have in the state of Nebraska. We have some, outside guests also here from outside the state. So we have a state arm, kind of an academic arm. The state arm of the HAI-AR program does all the monitoring of the HAI rates, initial outbreak response and consultation, and assisting facilities with data reporting and validations and partnering with the stakeholders. And the academic arm is basically providing guidance, education, support to the facilities across Nebraska and strengthening their infection prevention control program, developing resources and tools to help them. And they are divided into infection control assessment and promotion program, ICAP, or ASAP, which is Antimicrobial Stewardship Assessment and Promotion Program. All of that kind of fits into this team that is on this slide. I just added from last year two colleagues. You already met Jenna, who is our HAI-AR pharmacist and ASAP pharmacy coordinator. And then we will be welcoming Dr. Juan Terran next month as the ICAP medical director. He will be joining our team July 1st. Okay, so today we're going to talk about some trends in HAIs. We'll also talk about trends in multi-drug resistant organism, something on NHSN AER module, what we are doing, discuss a little bit about the CDC updated guidance to prevention and response to MDROs. Also going to go over Nebraska DHHS protocol for tracking MDROs and how are we keeping the facilities informed. And then supporting long-term care facilities with infection prevention control and antimicrobial stewardship efforts. And I will leave the talk with some updates on healthcare-associated Legionnaires disease. So, starting with the trends in HAIs. So, many of the infections that acute care hospitals are tracking right now, the CLABSI, the CARTES, the MRSA, bloodstream infection, and CDI. Our state has been doing well in that. We have, our infections are less than what is predicted for our state. So in that aspect, we are doing good there. But when we look at surgical site infection, that's where we start to see concern. With the surgical site infection, whether it's related to abdominal hysterectomy or colon surgeries, we have seen consistently higher SIR, which is observed infection that we are observing over what is predicted based on our hospital size and complexity. We have been above where we should be. Now, in the first quarter of 2023, we have seen a decline in abdominal hysterectomy, but we have to kind of monitor this trend that this is actually continuing versus just a one quarter kind of deviation. But overall, that has been a concern for us. And when we compare ourselves with other states, Nebraska actually has the highest SIR for surgical site infection following colon surgeries. And then fourth highest SIR for surgical site infection following abdominal hysterectomy. So that's one place where we don't want to be the number one, So we're going to have to a little bit do some work on it. And we have started doing some work on it already. Last year, looking at those trends, we developed or we put together a SSI, Surgical Site Infection Subcommittee, for our HAI-AR Advisory Council. That's Healthcare Associated Infection Antimicrobial Resistance Advisory Council that consist of very much relevant stakeholders. Some of them are in the room right now that advises the HAIR program. So they, with their input, we develop a subcommittee that is representative of 5 hospitals who are participating in this committee, including ID physicians, surgeons, IPs, and quality program leaders. And they developed a survey evaluating different practices, policies, procedures that many of the hospitals across the state are taking in surgeries, and what are they doing about preventing the surgical site infections. And they got a very good response. We have over 50% of our hospitals in the state responded to that survey. We are looking at that. The committee have not had a chance yet. We just recently finished the survey. They had not have a chance yet to look at the result of it. I was able to take a look at it quickly, but they will be deep diving on those data and then we'll come back. We're also providing one-on-one outreach and assistance to any of the hospitals who want to discuss their strategies in preventing surgical site infection. So that's also ongoing. So some of the findings from the survey that I kind of glanced, and we will definitely do more analysis and bring the data back to you, was that there were variations in auditing of aseptic techniques prior to and during the surgical procedures. There are variations in monitoring compliance with best practice recommendations. There are variations in standardizing and monitoring antibiotic prophylaxis practices. Some of the things where we are also finding differences are changing gloves and using a separate sterile fields, pre-operative mechanical ball preparation regimens for colon surgeries, vaginal preparation cleansing prior to abdominal hysterectomies, and perioperative screening and treatment for bacterial vaginosis. Now, some of these things, there are recommendations, some of them are considerations. So the people are doing different things, and what we want to look at is what is working for the facilities and what we should be avoiding. So all of those things will be looked at by the subcommittee, and they will come up with some guidance and recommendations for our state where we can provide that feedback to our stakeholders. So we'll be looking out for that to come hopefully soon. Now, I mentioned that we are doing good in CDI and some other infections beside the surgical site infection. And that may be true for our acute care hospital, the larger hospital system. As you can see, if we look at our PPS hospital, the larger hospitals, minus the critical access hospitals, we are in the middle of the nation in terms of our CDI SIR. When we are looking at the C. difficile infections in critical access hospitals that are reporting into the NHSN, that's where we start to see highest, again, number 1 in the country where we don't want to be, with the highest SIR for C. difficile infection. So that's concerning, that even though our larger hospital systems are doing better, but our, the critical access hospitals are lagging behind and are seeing C. difficile cases. So what are we doing about that? And there are some challenges here that I wanted to highlight first. So Nebraska hospitals utilizes what we call the NHSN group function to share the data with Nebraska DHHS. So it is a multi-step process. For those of you who work with the NHSN, you know that you have to confer the rights to the state to be able to see the data. And that is a barrier in many cases to do that extra step. And only 15% of the critical access hospitals that are submitting the data to NHSN actually is reaching to the state. They are all kind of in the federal cloud right now. So establishing a data use agreement with the CDC that will automatically report the NHSN data on behalf of the facility unless they opt out is the way that we think we should be going, so that we at least have the data to be able to provide the support to the critical access hospitals. So we are kind of moving towards that. We're working with Nebraska Hospital Association and kind of inform them about what we are doing in this room, and we are in very good collaboration. There will be announcement this month on this data use agreement by the CDC, so be on the lookout for that. And then many hospitals also lack, that's the second problem, many hospitals also lack the ability to report to NHSN AUR module, which is another problem, because if we are going to address C. difficile infection in smaller hospital systems, we need to understand the antibiotic use pattern there too. And that is not happening right now because they're not able to submit the data in many cases because of logistical reason, EHR reasons, or whatever they are not able to submit that data. If you look at nationally, Nebraska in 2021 has been, there were 13 facilities that have been reporting, 13 hospitals that have been reporting into NHSN their antibiotic use. And at that time, 54 hospitals were eligible, so we were around 24%. Now, 2023, we still have 13 facilities reporting to NHSN their antibiotic use, although our eligible facilities number have gone up since then. So part of that problem is that there is a cost associated with all of that, but there are benefits of AUR reporting to the facilities, correct? They get the benchmarking for stewardship, they can compare their trends, they can identify problems within a facility to target intervention, and then there are some regulatory benefit because in 2024, the hospitals are going to be required to submit the data to NHSN. Now, there will be some exemption for hospitals that does not have certain, certain capacities that they may get exemption. However, what we believe is that those exemptions are going to be short-lived, and at some point of time, they may actually go away. Now, I don't have any information about that. I'm just kind of speculating, but that is likely to happen just based on what we think this movement is going. So eventually, everybody will have to submit this data to NHSN anyhow. What we ended up doing, we ended up applying for some funding for the hospitals to be able to upgrade their system and able to get their data into NHSN AUR module so that they can work on it now. So there is a funding announcement just this month that went up on the website, and you can find that on the link here, where you can, where the facilities, any hospitals that do not already are submitting data to NHSN AUR module, they can actually apply for reimbursement for any updates they are making to the NHSN AUR module or any work that they are putting in terms of time of the staff that is going to validate the data or that's going to work with the IT team. So staff time, or the EHR expenses, they can get reimbursement for that up to a certain amount. So you can see based on the size of the facility, a small, less than 100-bed facilities can get up to $10,000, but a larger facility over 200-bed can get up to $20,000 for reimbursement on getting their systems updated for that. So I think eventually they will have to do that, but if they do it now, they actually can get reimbursement about it. So hopefully that all of that will help us then tackle the problem of reaching out, because that's a problem for us, that we cannot reach out unless the data is there, and we cannot provide the support that we need to provide unless the data is there. So once the data will be there, we'll be able to provide those support and be able to handle the request that comes in for providing that support. So moving on from reporting into NHSN is that what is already being reported, what are we seeing from that? So the 13 facilities that are reporting into NHSN, when we look at how we are doing in terms of antibiotic use, we actually at the 50th percentile. We're kind of in the middle again, we are, most of our facilities, over 2/3 of the facilities that are reporting actually have antibiotic use lower than what is predicted for them. So good. There's 1/3 of the facilities that have that are using higher than the predicted use for them. So there is still some work that can be done in this area. And we have been helping them and assisting them with providing some report on how they can actually work on it. Now, when we looked at the community side overall in Nebraska, outside of the larger hospital system that we talked about, that's where we still continue to see the concern. As you can see, we are consistently, year by year, over the national average of antibiotic use per 1,000 population here. So we're using 760 prescriptions dispensed per 1,000 population, as opposed to 636 nationally. And that has been a consistent trend for us. So this is an area where we still need to work. And we are brainstorming into that. Our next kind of initiative will be to reach out to the hospital systems across the state. Some of you are here, where we will work with you to see what we can do for your clinics and other outpatient network that you have, and can we do some collaborative effort or educational effort to get the stewardship program built in those settings. What we are also looking into collaborative opportunities with some of our insurance providers for targeted education. We are going to be expanding our engagement with primary care providers and professional societies so that we can have more educational collaborative in this area or addressing this topic. And then, from there, it's related topic. We are kind of jumping from antibiotic use now to drug resistance. Where are we in terms of our multi-drug resistant organism in the state? And as you can see, in general, overall, we are starting to see an increasing trend in Carbapenem-Resistant Enterobacterales. We just have a spike in 2022. Now, if you're looking at individual organism, you may see a varying pattern. So we definitely have E. coli's that were more Carbapenem resistant this year. If you look at Klebsiella pneumoniae, we're kind of maybe on the stable side. So it definitely organism by organism is different, but we are seeing an increasing trend for CRE isolates in Nebraska. When we look at whether these CRE isolate actually causing healthcare-associated infections, this is a comparison from the CDC from 2020, so it's a few years ago. And at that time, if you look at surgical site infection, all the surgical site infections that were caused by Enterobacterales, we had 6% of them were CREs. And when we look at the trend on all healthcare-associated infections like CAR-T, CLABSI, SSI being caused by Enterobacterales, and we start to kind of see where we were in 2020 and where we are in 2023, we are seeing higher percentages of those Enterobacterales being CREs now than we had before. So these are actual infections that are happening in healthcare. The national average in 2020 was 2.7. So we were still below the national average, but I think our trend, I don't know what's the national average right now. They have not released that data, but if they have gone up, probably, maybe, but we have to see what they are. But our own trend is going in the wrong direction here. So that still is concerning, and we still have to kind of keep an eye on that. Now, out of those CREs that we are seeing, how many of them are actually carbapenemase producing Enterobacterales, and those are the organisms that we are most afraid of because they are easily transmissible from person to person, and or even their genes can transfer from organism to organism also. So these are the organisms that we are most concerned about. Now, luckily, we still have low prevalence of these organisms, at least. Now, the 2019 year was an aberration in a way that we have multiple large outbreaks. So some of those isolates that you are seeing were screening cultures, but the rest of them are, rest of the year, what you are seeing is mostly clinical cultures. If you just see in 2022, I would say we had a spike. Now, you may not see when you compare it with 2019, but 2019 was not a normal year. So 2022 was an spike on our carbapenemase producing organisms. And in 2023, we're already projecting that we will surpass the number of 2022. And not only we identified the Enterobacterales that were carbapenemase producing, in 2023 we have already identified one case of carbapenemase producing Pseudomonas aeruginosa and one case of carbapenemase producing Acinetobacter baumannii. So we are starting to see these resistance coming up more. Like, we still low, but we are starting to see it going up. And in terms of the carbapenem-resistant Pseudomonas aeruginosa, when you look at this in the first glance, it might look like stable, that we are kind of in the same range. But if you just look at 2021, 2022, 2023, you may start to see a slow increasing trend there year by year on carbapenem-resistant Pseudomonas. So if you are, the blue bars are basically the carbapenem-resistant Pseudomonas aeruginosa, all isolates. And then the gray bars are the ones that are, in addition to be resistant to carbapenem, they are also resistant to cefepime and ceftazidime. And these are the organisms that we are actually testing also actively for carbapenemase enzyme when we see them. And they are also on the rise. So finally, I want to kind of go into the Candida auris trend. And, in the US, we are seeing an increasing trend in Candida auris. Actually, we saw a 95% increase in the US in 2021. In Nebraska, though, we have not identified any C. auris in 2021, we have not identified in 2022, and so far we have not identified any in 2023 either. So we have not identified. Now, it doesn't mean that it's not there. Maybe we are not looking hard enough, but I will say that we are looking at least some, or at least we are doing our effort to be able to recognize if it is here. So we have been educating the labs across the state in the misidentification potential of C. auris, because depending on what system you are using, and you can see in the graph here, there are different identification methods, and then there also in the last column you can see that there are different Candida isolates that they may end up identifying as. So that is the education that we are providing to the labs, that if you see some of those organisms and you're using that system, you may want to look further that whether this is a Candida auris isolate instead. So we're talking to them, we are letting them know there are labs that may not have capacity to even do the specification for the Candida that they are, or the yeast that they are identifying in the sterile fluid when they are getting cultures. So in sterile site cultures, if they are getting yeast in there, we are recommending them to send the sample to the public health lab so that we can get that identification done there. If there is a lab that is identifying an organism that they feel like they might be misidentified and they are meeting that criteria, they can send their specimen to the NPHL. And NPHL is doing some random testing also to identify whether there is Candida auris isolate. So far, the efforts have not identified any Candida auris. We are looking into, at least at this point, exploring, and we applied for funding already to see whether we can do wastewater surveillance for Candida auris and some other multi-drug resistant organism. We're waiting for those funding kind of approval. If we're hoping that we will get that, and we will be able to start a wastewater surveillance for the C. auris and some other MDROs also. So the CDC have just released earlier this year, updated guidance for prevention and response to MDROs. I will highly recommend, I don't have time to go into the detail of what it entails, but it is also for public health and for the healthcare facilities to follow. So there are prevention strategies there, and there are containment strategies there, depending on what kind of organism you are dealing with. So they define these organisms into 4 tiers, tier 1, tier 2, tier 3, and tier 4. And whether you take the containment, prevention, or both is going to be depending on that tier of the organism. The tier 1 organisms are the ones that are never or very rarely identified in the US. So the tier 2 will be the organisms that are that we know exist, but in our region, it may not be that common. And then the tier 3 are the ones that are becoming more common, but have not yet become endemic. And then tier 4 are the organisms that actually have become endemic in our region. So, we put examples there. So, for example, a tier 1 organism for us will be some kind of a novel Carbapenem-Resistant that we start to see, and then in that case, that becomes a tier 1 organism. The tier 2 organism for us will be right now will be like Candida auris or any Carbapenem-Resistant producing organism. We don't think that there is a tier 3 organism for our purposes yet, and then the tier 4 organisms are going to be our MRSA, VRE, ESBL organisms at this point. So mostly what we are dealing with in our day-to-day work is the tier 2 organism at this point at the HAI-AR program, where we are doing our level best. So what does the CDC recommends, what the response elements are, is that when you identify a tier 2 element, you have to look at the patient exposures, so in the last 30 days. So if a patient is identified with a tier 2 organism, we look at where that patient was in the last 30 days, within the hospital, nursing home, which outpatient clinic that patient went to, and then we start to kind of do some screening and of the healthcare context of those patient. And then after that, we don't do that much of household screening, except if there is a spouse with a high risk. We have done that in some situation, but it's not a usual for us. And then when we go into additional actions, if you identify transmission within the facility, then you have to start looking into what we call point prevalence studies, where you go in and do the swab for the entire unit or entire building, and start to kind of look at whether this is a more widespread problem than what you have already identified. And finally, in terms of laboratory surveillance, you have to look at retrospective lab surveillance and prospective lab surveillance, meaning that if you have identified an organism that is a tier 2 organism, you may want to go back 3 months in the lab and see whether there were other organisms like that, or 3 months forward, kind of continue to keep a very close eye and get specimens and bank specimens and store specimens to be able to do whole genome sequencing if needed, if they are coming forward. So all of that, we communicate with the facilities when we are talking to them after identification of a tier 2 organism. In terms of the infection control measures, we definitely notify the healthcare providers promptly. We ask them to flag the charts. We offer them infection control assessment at the facility, and there is very clear communication that we do about patient transfer, and we want you guys to be able to have that information freely flow when you're discharging the patient to another facility. But we are also trying to help with that as much as we can. So our process right now at the State Health Department is that when we get a lab, so the labs are usually reporting the cultures to the state through electronic reporting. Our team runs the reports daily to identify these targeted pathogens that we are talking about, CRE, CRPA, CRAB, and then if we find one, we tell the NPHL about that. The NPHL then reach out to the lab from where that culture was originated, and they ask them to send that isolate to the NPHL. Then the NPHL will perform whole genome sequencing on their isolate, they will perform the carbapenem testing on those isolate, and if the carbapenem enzyme is positive, they will let us know and they will let the lab know. We will then let you know, and they will end up doing whole genome sequencing on those isolates. So that's the process. Although what we are identifying, what we are telling the lab is don't wait for us to give them a call and say, hey, you have this organism that requires additional testing for carbapenem. Send that sample when you see the resistance pattern yourself. If you are seeing a CRE, send that sample to NPHL. Don't wait for our call asking for the sample, because by the time we call, it might be possible that the lab has already thrown away the sample. So that's one of the messages that we are giving to our lab partners. Now, what happens once we know that this is a carbapenem producing organism? We, at that point, you use that information not only to notify the facility, but we also add an alert on the Sync Health system, which is our health information exchange. Sync Health system, that alert goes in there, and we are able then, the state is able then to track if that patient ever gets admitted to another hospital, to an ED, or he get discharged from a hospital, we get an alert on that patient. Then we call you or the infection preventionists at the facility, and we tell you that, you have a patient that has been identified having carbapenem production, is now in your ER. So that is the process currently. We will give you a call. You will get a call, and some of you have already received those calls. Now, you may already be aware of it, and sometimes you may not be aware of it, but we are trying our level best to be upfront. Now, where we want to be is that instead of just us getting the alert, we want your infection preventionist at the hospital or any designated person to get that alert too, if you will want to. And we are working with the Sync Health team to be able to develop that capacity where a facility designated person can get an automatic alert when a particular person who is flagged for a targeted MDRO enters the building. Now, we're also working with the Sync Health to add a flag to the clinical portal of the Sync Health, so that when someone if someone is reviewing somebody's chart, or a nursing home is admitting a patient and they have access to the Sync Health, they can go in and review the flags to see whether there is a flag or not. And then we are trying to explore whether we can add that information into the PDMP. So that's another area we are looking at. So all of this work we are exploring right now. We are hopeful that we may be able to get it done, but this is a process. So I cannot promise anything, but at least we are looking. What I can promise is we're going to keep trying. So just want to pivot a little bit in the last few minutes I have left to what we are doing for the long-term care facilities specifically. So first of all, you all know that the ICAP team and the ASAP team has been assisting with all the outbreaks in the long-term care facilities. What you may not know is the amount of how many outbreaks we have seen and how many outbreaks that we have assisted with. About 4,000 outbreaks from the start of the pandemic in the nursing homes that we have recorded. And our team has assisted with 85% of those outbreaks. Now, if you see, in the first couple of years, we were kind of assisting with 100% of them, and now our numbers with assistance is going down because there is a lot of places now where you have so much experience that you can deal it with yourself with just a little guidance and, or the written guidance that we have made available. But there are still a number of facilities that are requiring some guidance and some, work that goes along. So we still continue to do that. Just wanted to give that picture. You can see, how many consultations we have done, how many structured IPC assessments we have done, and on the other side, you're seeing the graph there that is telling you about the COVID-19 therapeutic support that we provided to the long-term care, where any one of the nursing homes anywhere in the state can request, and our community partners, community pharmacy partners have helped with us a lot on that one, where any pharmacy any nursing home or assisted living facility can just request a review of their patient who is being diagnosed with, or resident who is being diagnosed with COVID-19, whether they are eligible for that COVID therapeutics, and if they are eligible, if there are drug interaction that needs to be managed or not. We have about 2,500 of them that we have done since November of 2020. And we still have, we're not dispensing the medication anymore, but we are still available to review and provide you with eligibility determination or drug interaction issues. We are still providing that support at least. Again, there's a lot of work. Wanted to give the shout out to the teams who are doing it, shout out to the partners who are helping with us. And one other thing that we are about to start is a long-term care consultant pharmacist training series. That is starting hopefully in the next couple of months with Nebraska Pharmacists Association collaboration. So this is a big deal, correct? We don't have at a national level good, established training program for long-term care pharmacists to get training in stewardship, how to do stewardship in the nursing homes. So that's where we're going to start doing it hopefully in the next one. It's going to be a one-year program. Once a month we will meet, and this will be a collaborative effort that will happen. So more information to come on that. We're also, most of you probably aware of the Strike Team project. In the Strike Team project, we are assisting nursing home with implementing respiratory protection program. So they are able to get their own N95 fit testing equipment. They can get their staff trained on how to perform fit testing so that they have internal capacity to do that. They're also able to, and they can get some reimbursement for those efforts too. And they can also get reimbursement to train infection preventionists, additional infection preventionists in their building, and some infection control champions. So all of this reimbursement amount I've listed there. I'm not going to go in detail of that, but it's available on the website. You can see that. Plus, we are also working with the health department to provide some education and training in the health department to develop local HAI-AR expert who can work with the state team to help the nursing homes in the jurisdiction on any HAI issue or any antimicrobial resistance issue. Okay, for some reason I'm not forwarding. Okay, so far, nursing, local health departments have received the trainer training, so they are able to train anyone in your building on how to perform a fit testing, and they can hand you over some fit testing material for you to train to fit test the rest of the staff. And then there are about 83 facilities that have mentioned the interest to participate in this project. 54 of them are not sure, but they are looking into it. They have not declined. 31 long-term care facilities have already received, out of those 83, 31 have already received fit testing support from the local health departments by this time. So this project is going well. So hopefully we'll see as we go forward some good outcomes out of this. Last thing that I wanted to discuss, and I think I'm coming to the end, so good. So last thing I wanted to discuss is we need to keep an eye on this. Since 2022, so in the last 1.5 years, we have identified 5 cases of healthcare-associated Legionnaires' disease in 4 different healthcare facilities across the state. The Legionella, in addition to those 4 facilities, Legionella has also been identified in surveillance cultures as part of the water management program in few other facilities. So there are multiple facilities which are dealing with the Legionella problem right now across the state. So in response, we have enhanced our surveillance effort. We are increasing focus on providing education for developing and implementing water management plan. We are exploring possibility of grant funding to enhance the capacity of water testing for Legionella through public health and environmental lab, at least during outbreak in a healthcare facility. And then the major challenge that we face with that is that there are many cities across the state that do not chlorinate their water, so mitigation effort can become more difficult. So having a good water management program is essential at this point. We'll keep giving you updates as we know more. So in summary, Nebraska hospitals are doing better in preventing most healthcare-associated infections, but there are opportunities, as we identified, in some areas for us to improve. Now, even though our total counts for some of our targeted MDROs remain low, and that's a good thing, but there is an upward trend in the numbers, and that is concerning, and we need to kind of pay attention to that. Most of our larger hospital systems are doing an excellent job in keeping antimicrobial use low, but we need some additional efforts with our smaller hospital system to provide them the expertise and the support to do the same type of efforts. And we are working on that too. Existing partnership and collaborative relationships is the key, so thank you all of you guys that are working with us to get things going for us and for our state. We will continue to expand our collaboration with you and the local health department and the professional organization and the other stakeholders to bring all these patient safety initiatives that we are working on right now, and that I will stop from there. Thank you very much. Any questions? And if there are none question, I will still be around. Oh, looks like there is.
Good morning. Another fabulous presentation. I'm curious, and this may be not a fair question to ask, with the looking for Candida auris in the sewage treatment in wastewater, once you find that, then what? What happens after that?
So that's a very good question. So I think part of that is also going to be making the case to do more broad range screening, prospective screenings and things like that. But I think as of this point, if I ask this group in front of me to say, okay, let's start, admission testing on this and this group, or, this group, they may, our IPs here, they may get some pushback from their leadership and things like that. But if we can demonstrate that we have Candida auris in our state, then there may be more buy-in in there. That's our thought process. That's the reason that we are kind of pursuing that, to at least if we can see the Candida auris in the wastewater, then that's not an issue of like we have it or not have it. We have it, we just need to find where. So that's basically the thought process behind it.